If you would like to work directly with Dr. Kole to maximize your sleep quality with a comprehensive sleep coaching program, or if you're concerned that you have sleep apnea, or simply just want a second opinion consultation, she's now available to see patients in New Jersey, New York, California, and Georgia, with more states coming soon. Please visit oak.care/sleep for a complete list of telemedicine services with transparent pricing. You deserve rapid access to quality sleep care with a physician you can trust to have your back every step of the way on your journey to better sleep.
Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Welcome to another episode of the Sleep is My Waking Passion podcast. I am so excited today. I have met a new friend and colleague, Dr. Funke Afolabi-Brown, and I nailed her name score. So Funke and I sort of connected. It was like friends of friends, just mutual admiration. I had to talk to her. She is similar to me in that we're both pulmonary trained, and she focuses a lot. She takes care of adults as well, but she is really a pediatric pulmonologist and sleep specialist. She was up until very recently at the University of Pennsylvania. This is a very, very smart lady. And she is now CEO of Restful Sleep MD. And from what I know, she is offering sleep coaching and she travels sharing her wisdom. She is doing conference speaking. She's doing consulting. She is everywhere if you looked her up on LinkedIn. But Funke, why don't you kind of share with folks, what your vision is and what they can see you for? I'm going to let you take it away.
Oh, gosh, Alison, I just love your work. Thank you. Sleep is my waking passion too. So thank you so much for having me. Yes. And so, what's my mission? Really, my mission is to empower families, I would say, specifically busy women and their kids, to change their relationship with sleep, because it is a superpower and it is very, very underutilized. And my mission is to change that. And yes, it seems like I wear a lot of hats, but they all just feed into the same thing, which is sleep. Really, whether it's in organizations I'm talking to or, conferences where I'm either speaking with, sleep technologists or, sleep physicians or other experts, it's really advocating that sleep becomes a thing. And also the coaching is something that I've been so passionate about, because you really get to delve into what is it behind, what are those limiting beliefs we have around sleep, not only from a perspective of insomnia, but just around being able to prioritize sleep as a fundamental aspect of our health, right? So that's one of the things I do with women. And it turns out that, kids also get in the way. So, I'm all about that as well. Like you said, I do help kids sleep better too. So it's just been a delight, and I've just really enjoyed this journey. And I think one of the blessings I've experienced with this is, connecting with incredible people like yourself, right? And seeing that, there's so many of us on this mission. Well, not that many of us, but there are people with the same mission, with the same goal of really making sleep a thing. So, I'm thrilled to be here.
Oh, and when we talked, I was like, you're going to be the perfect person, because there's something about obstructive sleep apnea. We all can treat it. A lot of us are very familiar with it, but there's something very unique about having that experience as a pulmonologist, as a lung specialist. I think we do get some very special training, especially when it comes to using more advanced modes of ventilation. Some of the things that just intrinsic to our profession and dealing with folks that struggle with their breathing, that we really get that extra training on. So without further ado, this episode is called Let's Talk Sleep Apnea. And I made that very general on purpose. We're going to focus sort of on what the most common type of sleep apnea is, which is obstructive sleep apnea. for the sake of time and just generality, because I've gone over this in some of the other episodes, I'm just going to summarize adults, but really want you guys to stick around because this is really a discussion that encompasses not only adults, but also children. So you're going to learn a lot of information, and I am truly relying on this expert to help me out and understand kids, because I'm very comfortable with the teenagers, kind of because they're like mini adults already. But when it comes to the real small kiddos, I'm like, you need to go see Funke. I'm not the right person for you. But, just in quickly summarizing, adults, what we're looking for is we get concerned when folks are falling asleep at night. And obstructive sleep apnea really is a relaxation of our upper airway muscles, sort of outside of the chest cavity. So we have our tongue muscle. We have all these muscles that help us swallow and control our airway that we don't even think about during the day. And when we go to sleep, these are really voluntary muscles and they relax at night. And if you go into rapid eye movement sleep, which is a normal stage of sleep, they're actually paralyzed, believe it or not. So we really have the ability to compromise our airway. I think one of the things we're not quite sure about is why some people develop it and other people don't. It may be related to just how we're anatomically built. We do know that there's some things related to just, whether our ethnicity is, our gender can affect it. We're going to get into the weeds a little bit with that information. But just keep in mind, when we talk about obstructive sleep apnea, we're talking about the classic person who might snore, where people are like, I think you're not breathing properly at night. Like you're gasping. They may not even recall any of these events occurring, and they may feel really fatigued during the day, or they may have trouble sleeping. And what we look for is whether or not the upper airway gets so small that you're trying to breathe. We see effort, but you're actually unable to. So we call that an apnea. That's where that name comes from. And we're also looking for events where, we still see a little bit of flow, but it's so minimal that you actually cannot properly oxygenate. And when we watch your oxygen levels, we're seeing them repeatedly fall during the night. And, if you have more than 5 of these events per hour, if for an adult patient, we say, yes, guess what? You've got sleep apnea. And we have this grading system, mild, moderate, severe. I will say in a nutshell, I don't emphasize that as much these days because I think there are many ways to skin that cat. In terms of how you interpret mild, moderate, severe. But at the end of the day, if you're having symptoms that are significant enough to disrupt your sleep, it doesn't matter if it's 5 events or 50 events. There's a problem here. And so that's really what I wanted to emphasize, is that less about the severity so much as really what we're looking for is symptoms and then how that might correlate to your overall health. So I'm going to stop there in terms of talking about adults with sleep apnea. And Funke, can you please take it away and share with folks, what you want them to know about pediatric kids having obstructive sleep apnea?
I love the summary. I love how you've put this. I think with children with pediatric age group, there are few similarities, there are quite a number of differences. So, really when we talk about who gets affected by sleep apnea, most people, like you mentioned, it's like that, sometimes there's that stereotype, right, of the male with certain risk factors. But it turns out kids, even from that newborn period, are at risk. Some children are at risk of sleep apnea because there's so many factors that feed into this. There are, you could say, maybe anatomical factors. And so if you have a child who either has an underlying syndrome or some facial or what we call craniofacial abnormalities, so maybe in children with conditions like trisomy 21, who maybe have lower tone, again, that tone piece comes in, they have hypotonia, and then they may also have sort of what we call some facial differences, mandibular, we call it mandibular hypoplasia. Things are just a little bit smaller, things are a little more squished, and you may start to see manifestations of sleep apnea even from that early, from that newborn like stage where they're in the nursery or in the NICU.
Oh, and I just wanted to clarify, I don't mean to interrupt, but I just wanted to just point out to folks, trisomy 21 is really what we call Down syndrome. So if you're familiar with Down syndrome, that's what we're describing. Okay, take it away. Sorry, my apologies. I just wanted people to follow our convo.
Absolutely. Thanks for putting that up. So yes, what we know as Down syndrome. And then a few other syndromes as well. A few other genetic factors can lead to sleep apnea in children, again, because of a lot of times, either because of the tone issue or because of the structure, the structural issues, right? And then another sort of anatomy factor is, what is it that's blocking that airway at night where your child is trying to breathe, but there is some kind of obstruction. And the most common that we see is big, what we call tonsils, which is right at the back of your throat, and adenoids, which is just this tissue that's at the back of your nose as well. And it serves a good function, kind of helps with filtering of particles and stuff like that. But during certain stages of life, it starts to really, really grow. And so it starts to become a nuisance. And so a child who is snoring, I always say, initially it sounds cute, but if it's habitual snoring, meaning that they're snoring more than 3 nights a week, you need to pay attention. You need to get the child checked out. Why? Because again, just like Alison, just like you mentioned, you're having these pauses in your breathing against this obstruction. And so repeatedly doing that overnight, one, is decreasing your body's ability to get in oxygen. And we need oxygen for our brains. We need it for our hearts. A child with a developing brain that's getting that kind of sort of fragmentation in how they're getting oxygen is going to impact them over the long term. And then the other piece that we see a lot in pediatrics is we get frequent, and you see it also in adults, of course, we get frequent kind of awakenings. So now your brain is smart. It knows, okay, I need oxygen. I am feeling under stress right now because this airway is closing up and I'm not getting the oxygen. So your brain is going to trigger that arousal. And so every time that child is trying to get into either really deep sleep or what we call REM sleep, and I think you've talked about those stages of sleep on this podcast before, where in REM sleep or rapid eye movement sleep, your muscles are literally paralyzed. So in that stage, apnea tends to be worse. And so every time your child is trying to get into those stages of sleep, an arousal comes up. And so they get this really fragmented sleep and they wake up and are exhausted. In an older child, you may see them have daytime sleepiness, kind of like adults. But in young children, they actually are hyperactive and overtired. And that's where you start to see the inattention, the impulsivity during the day, excessive daytime sleepiness in some situations, or just, emotional outbursts that seem to be excessive. And then on the long term, of course, we start to see this impact. Now we're seeing studies that show that just like in adults where you have untreated sleep apnea causing higher risk of heart problems, hypertension, diabetes, obesity, things like that, we're also seeing it in kids as well, especially as they get older. So definitely a few things are kind of different in terms of what causes it, sleep apnea in kids, but then there's definite similarities as well.
Question for you. So for those kids that are exhibiting the inattention, the hyperactivity, they may often get labeled as like having ADHD that's adult, but the same concept, like attention deficit hyperactivity disorder. I'm saying it right now. Now, can you tell me anything about like data? Are those things, is it like ADHD and OSA, or is it that really this diagnosis of ADHD may really, in other words, are they comorbid? Are they together? Or is it really that the ADHD isn't really a true diagnosis and the OSA management, if you discover it, actually may take care of the ADHD?
That's an excellent question. And I would say that, that diagnosis of ADHD, we're seeing a lot more of it now. I'm not aware, and I could be wrong. I haven't seen what's been more recent, looking at like pure samples of children with ADHD and actually seeing what the prevalence is of obstructive sleep apnea specifically. But we do know that children that have, ADHD, there's been studies, and also children that have, conditions like autism and other neurodevelopmental conditions. There's studies that are showing that there is prevalence as high as 70%, prevalence of sleep problems in these children, as high as 70%. In some studies, actually a little bit more. And now it is a whole bucket of different sleep disorders. So it could, or sleep issues. It could be insomnia, right? Where they're having difficulties with sleep, with falling asleep or staying asleep. It could be conditions like restless leg syndrome. It could be obstructive sleep apnea. A few studies we're seeing here and there. Again, some of them have really, really small numbers. So it's really hard to say like, is this true? We do need larger numbers that are shown that children with ADHD do have a higher prevalence of obstructive sleep apnea. Now, what does that mean? Does it mean that they're just getting screened more than your average child who is, snoring, but otherwise seems to be doing okay? You know what I mean? So I think there might be a little bit of a selection bias with that. So it's really hard for us to be able to say absolutely, but we definitely, even from my experience, just anecdotally, we definitely see such a higher prevalence of sleep disorders overall. Now, in terms of what happens when we treat these children with treat their underlying either sleep apnea or underlying sleep disorder, is that yes, we do see improvement in their behaviors. We do see improvement in their mood, in their attention, and actually, in their overall performance. So definitely something that is worth looking into, and which is why, like, I'm so thankful I get to be on this platform and say, well, if you have a child who is, there are reports that you're getting notes from school that, they need to be screened for ADHD, they're not paying attention. I'm not saying the child may not need medications or things like that, but please just consider advocating for your child to get evaluated for sleep issues as well. And I may not explain 100% of what's going on, but I can almost assure you, if you can optimize their sleep, looking at the behavioral causes, looking at the medical issues. One other medical issue that we see in children with underlying developmental issues is things like restless leg syndrome, as well as some circadian rhythm disturbances. So again, advocate for your child to be seen and evaluated by a sleep specialist as we continue to provide all the behavioral support and all the other screenings. I think that's really going to be key, because it does help.
I love what you're saying. And really, what I hear from you in summary is that it's all about being comprehensive. You're not saying because of this, you do this. It's like, listen, there's going to be multiple things that go into optimizing your sleep, and it's important to look at the whole person, the whole situation, and how you can best optimize that. So well put. So well put. I wanted to ask you this because for adults, men and women tend to have little nuances. Now, you touched on some of them. The classic, even what we call phenotype or type of patient that we typically think of with a male is they may be heavier. You mentioned that there's a lot of associations with things like high blood pressure and diabetes, coronary artery disease. Can I talk today? And those types of things. And yes, those are important influences. And then just how they present, they often may say, well, I've been told I really snore very loudly. And they may or may not be aware of some of the other symptoms. And also daytime fatigue tends to be that like stereotype of the men. Whereas women, I think it's almost like, oh, women just don't have as high a risk or what have you. And really, some of that's a little bit of a myth, because what we know is that, yes, if you were to look, and this is like really old data, but if you were to look across the population, it's estimated that maybe up to a quarter of men are at risk for sleep apnea. Women, they're like, well, the prevalence is much lower. It's probably around 9%. But that's not necessary that it stays that way over time. So once women start hitting their older middle age, they may be perimenopausal or menopausal, now you're having hormone shifts. Women often gain weight during that time, as we all know. Just can't keep the body that we had in our 20s. And, we're just going through a lot of changes with respect to that. And so we do know that for various reasons, be it change in BMI, we do know that progesterone can be protective of the airway. It actually may have some physiologic benefits to keeping our airway open. And then as that hormone diminishes, then our risk really goes to that of men as we get older in age. So there is that sort of gender discrepancy. For kids, is there any kind of gender discrepancy that we need to also take into consideration?
So within prepubertal, there's really no difference. The male to female prevalence is the same. Post-pubertal, we start to see a slightly higher prevalence in males. And then I would say now things are also changing significantly because we now have the obesity pandemic, right? So that also plays a huge role, and that tends to be a risk factor that we also have to kind of guard against when it comes to just those comparisons. But until close to by 12 or so, they're about the same. Then you start to see that over slightly higher male predominance. Now, what does that look like if we try to control for obesity? That I'm not sure about, but I think it's going to just really swing towards that as a risk factor in and of itself.
Such an amazing point, because yes, we can get into a whole separate discussion about nutrition in this country, particularly in children. But I have definitely seen, and this takes me to another comment, which is I think socioeconomic status, where people are at, there are health disparities that are worth pointing out. And maybe it's just my observation, but I feel like, when I was working kind of in a county facility where there were a lot of kids that maybe were underserved compared to the population that I, have seen in private practice, for example, I noticed that discrepancy even amongst the kids. I feel like, I don't know if there's data about this, but obesity seems to be very rampant, and ironically enough, in folks that don't technically have as much cash as other folks. It's wild.
Mm-hmm. It is, and it's the same. The data here with pediatrics is very similar. So lower socioeconomic status, we're seeing that there's actually a higher rate of obstructive sleep apnea, of sleep disturbances like insomnia as well. Of course, those kids also tend to have overall decreased total sleep time. There's so many factors that contribute to that, right? Housing insecurities is a big one. Noise pollution, light pollution. Again, the obesity is driven by what? Yes, maybe poor dietary food intake, but also lack of physical activity, right? If you have that child that you in your practice is saying, oh, okay, you got to lose, 10 pounds. And he's like, well, it's not safe outside, right? I can't, after school, I got to sit indoors and wait for my mom to come from her third shift because I can't step outside. I can't go to the park. Right? I can't walk around the block. It's not safe. So there's so many things that drive this inequities that, it's, again, it's like a whole different episode I would tell you. But yeah, it's definitely a big factor.
Well, I'm glad that we're bringing it up here, because anybody in the general public needs to understand that if you really care about improving sleep, you got to really consider all of these other factors. And I also think that if you're a person who's listening and you're like, oh, this doesn't really, this isn't my reality, that's great. And I think it's just one way to sit there and say, let me take pause, because I'm learning something about how sleep apnea is affecting folks that may not necessarily be in my demographic, and just be grateful that that's not the demographic I'm in. That's a blessing. And I'm all about these days really trying to find like that one little like nugget of like, what's positive? Let me focus on that, because it begets more positivity. So that's like a life lesson that has nothing to do with sleep, I know, but still, I think relevant. I did want to just point out one other thing, which is ethnicity and where our genes come from can be very interesting in changing how folks look at sleep apnea. I'm going to come from the background of being half Asian and say that it's been a wild ride to see that there are a lot of folks in Asian cultures where they're not even like sleep apnea is not even on their radar. I'm firmly committed now. I don't have any proof of this because she did not have a sleep study, but I had an aunt of mine in Korea who really had symptoms of sleep apnea. And what they did at her church is they had a whole room filled with older Korean folks that just napped like after they got to church. And I'm like, do you think that maybe y'all need some sleep studies? But, I'm just the random American doctor. So, I probably shouldn't even say anything. Like my relatives were sort of like, okay, that's cute. Okay, well, let's move on from that discussion. But, there's something, I mean, she had a shorter neck. She looked a little different than my mom. And she had sort of that recessed jaw a bit. So she definitely had the appearance of someone who could be at increased risk. And I just wanted to point out that I have taken care of, and I'm sure you have as well, countless thin Asians of all persuasion, be it if you're, South Asian, Indian, Vietnamese, like you could just run the gamut of Asian culture and you do not need to necessarily be obese. And yet these folks can have pretty substantial and bad sleep apnea. And so when we look at talking about things like sleep apnea and we try to kind of lump together symptoms and everything, it's just important that we keep a broad perspective. And if you're an Asian person and you're listening to this podcast and you go, well, I've been told I snore, but I'm thin, I don't kind of meet all these criteria, think again. And if your provider is like, you probably don't have it. Look at you. You're a normal body mass. And like, what? I'm not worried about you. I think that's an impossibility. It's not impossible. And it can happen. And if you're not sleeping well, just advocate for yourself. Push the limits, poke the bear, because you may be surprised at what you find. I know that African Americans, Native Americans, Hispanics all have a higher risk. Did you want to make any comments regarding that you think would be helpful to the listeners?
Yeah, I mean, I think you're absolutely right because, again, with the genetics piece, I think that's still stuff that it's kind of unraveling, right? Some of it is related to, again, the anatomy, right? Sometimes it's a recessed jaw. Sometimes it's sort of the flatter face, which again is crowding that upper airway. One group of people that I've done quite a bit of work looking at with some of my research when I was at Penn is patients or children with sickle cell disease. And so they actually have a significantly higher risk for sleep apnea. And, one could be because, again, majority are African American. Another could be because they have what we call the sort of we call it lymphoid hyperplasia. So most times when you have sickle cell disease, most of the time these children have they lose their spleen very early. And that's because of all the work that their body has to do because they're going into crisis and their blood counts are low. So their spleens are overactive very early and at times eventually shuts down. And so other parts of your body that's responsible for fighting infection, those are the lymphoid tissues. Remember, we talked about those tonsils, we talked about the adenoids. Those are all examples of lymphoid tissues. So all those areas may try to compensate. And so they get bigger too. And so these children may be at risk for more sleep apnea because of that. And also because they are, African American majority are, and those populations are also at risk just independently for sleep apnea. So that's another group that we definitely do need to pay attention to because we know, right, for children who have, or even adults who have sickle cell disease, they get into crisis when they're exposed to low oxygen saturations, right? So they have this episodes of hypoxia, which can put them at risk of getting into a crisis or having acute chest or lung problems that lands them in the hospital. Sleep apnea cuts your oxygen short, right? So you're having that intermittent oxygen sort of desaturation, drops in your oxygen level. So combine that in a person that's already at risk just because of their genetic makeup, and it's a room for disaster. So absolutely what I recommend is if you have a child or an adult that has sickle cell disease and maybe is snoring, or maybe is not even snoring, you're just like, the oxygen just seems unusually low sometimes when they're sleeping, please get a sleep study so that they can get treated, because that in and of itself can put them at risk.
I happen to be working on a grant that's related to sickle cell disease, and my mind is blown. I really did not know this statistic. Thank you. I am smarter now. I love this. I love what I do because I can be smarter. Oh, this is wild. I really, it makes complete sense the way you're explaining it, but I just would never put two and two together and really think that there could be that association. It's fascinating. All right. Well, I'm going to, I know you've got to have a unique perspective on this with pediatrics. I'm going to talk a little bit about a less known type of sleep apnea, but one that I happen to get a ton of questions on. People are often like, well, do I have central sleep apnea? So when we're thinking about central sleep apnea, really what it amounts to is when we're breathing. And one of the drivers for us to breathe, it's going to be related to your oxygen levels, but also related to how our bodies handle basically the byproducts of metabolism, which is carbon dioxide. And so we have in our brain basically a ventilatory control center. So our lungs function to help bring oxygen in, but also to expel carbon dioxide. And part of how we breathe and how we respond to certain things affects how, everybody has sort of a different way that our brains control our ventilation, in a nutshell. So what we look for with central sleep apnea are times where people will literally just pause when they're sleeping, and they will not breathe. Now, there are times when this can also happen during the day, but generally speaking, I'm going to focus on sleep for the sake of this discussion. It's basically like if I was looking at you, unlike obstructive sleep apnea, where I mentioned you're trying to really expand your chest wall, your body's trying to breathe, but your airway is closed off. This is just like, oh, I'm not breathing. And there's no effort and there's no airway closure per se. You just stop breathing. So, some people are just, their response to changes in their carbon dioxide levels, they may tend to breathe a little bit faster. And then that leads to an apnea. And, for other reasons, sometimes people actually have the opposite response. But I just wanted to touch base on a couple of things that we often see in the adults. And then Funke is going to share with you some things that we can see in kids that are sort of interesting. So one of the most common presentations of this that I see is what we call sleep transition apnea. So I've seen this so many times where people will be like, well, I'm just starting to fall asleep. And then I notice that I gasp. And oftentimes what's happening is it's just the way you're breathing. You may be kind of breathing to the point where your carbon dioxide level falls a little too low. And then your body just goes, okay, we're going to have an apnea. And it often happens around the transition between sleep and wake. And what I can tell you is, I typically try to really just reassure patients because it's not dangerous. It's just something that sort of normally happens. And some people are a little bit more quirky. And I think sometimes once you notice it, the problem, as we know with sleep, is once you start to notice sleep, it almost works against you because then you're like continuing to think about sleep. And so when you recognize that something like this happens, sometimes it triggers you to be like, oh my God, it's happening. And like, it's almost like a cycle where you're almost too aware of what your body is doing in that particular situation. Now, there's times when people can, may need to use other types of ways to treat it. But generally speaking, I just sort of try to reassure patients. The other common thing, and I think it's really applicable to what's going on in the world today, especially with our opiate epidemic, is narcotic use, the opiates. This is one of the reasons it's so dangerous, is that it literally just does, when you are on all of these narcotic drugs and you hear about fentanyl overdoses and all of this, it's basically just suppressing your drive to breathe. And that's really what often kills folks that are using these illicit substances or abusing substances that are prescribed to them that are in the opiate pharmacopoeia, because you're essentially taking too much of this, lowering your respiratory drive, and it's really a respiratory failure that occurs that causes you to stop breathing. And so that is another reason that we see central sleep apnea. The last one I'm going to mention, just because it's common, and sleep apnea, specifically obstructive sleep apnea, is so tied to our cardiovascular health, is this breathing pattern that we call Cheyne-Stokes. And it's often, but not always, but often associated with folks that have problems with their heart. Their heart may be too weak. It's not pumping strongly. And as a result of that, they have periods of time where they breathe kind of fast and then their carbon dioxide levels drop. And so then you stop breathing for long periods and then you breathe real fast again. And this is sort of like a I don't want to call it periodic breathing because that's a little bit more complex, and I probably wouldn't be doing justice to my colleagues who know exactly what periodic breathing is, but it's basically a form of breathing that we see with heart failure in summary. So, yeah, I mean, there's so much. This topic goes deep when it comes to pediatrics, but I'm going to punt it your way. And, maybe you could share some insights into the pediatric population for folks and obviously any overlaps with adult, please, by all means.
Absolutely. So with central sleep apnea in children, like you said, there's such a wide gamut. Oh my goodness. If I could get a penny or a dollar now because of inflation for every
Inflation.
for every consult I get for central sleep apnea on their sleep study. Oh my goodness, that's like, it would be like a whole industry on the side. Anyway, yeah. So the thing about it is with central sleep apnea in children, the criteria, and I mean, we didn't really go even into detail about, because that's, again, there's a big topic. The scoring criteria based on a sleep study is so different that with brief pauses in breathing in a little child that leads to a brief desaturation that meets specific criteria, all of a sudden it gets scored as central. So sometimes we get what we call physiologic centrals, which is essentially your body pauses because sometimes you just have a brief pause and it's really not causing anything. So when we're really looking at central sleep apnea, especially in children, or central apnea itself, before we decide a patient has central sleep apnea, we're looking at, okay, what does the duration look like? Is it like this brief 6 or 7 second apnea? Remember, a child is breathing so much faster, such that if their normal respiratory rate is like in the 30s, for instance, if you have an infant, if they have 2 pauses in that, it suddenly gets scored as a central apnea, especially if there's a brief desaturation, right? So we have to look at the duration, and then we have to look at what does the gas exchange impact look like? Like, is this child's oxygen saturation melting? Then in which case, okay, so we got something going here. Or is it just a really transient drop in their oxygen that really doesn't have any consequence? So we have to sort of take all that into consideration. So I'll put that on the side because we call those like physiologic central apneas, and really we don't do much. Again, it's more of reassurance. But now in terms of what are the broad causes of central apnea in a child, we have what we call central sleep apnea of prematurity. That's where a lot of people might hear that apnea of prematurity, where you see children whose brain stem, because of that premature age and sort of more underdeveloped lungs, they are more at risk for forgetting to breathe. And so they have a lot of what we call apneas and bradycardias and desaturations, and they need to go on an apnea monitor. And then eventually they outgrow it. Sometimes they maybe need to be put on some certain medications to just remind them to breathe. So that tends to work okay over time and they get better. Then we start to then see, okay, this is no more a child within that premature age group. This is now a child who is having these episodes of, relatively prolonged pauses in their breathing that's driven by their brain forgetting to kick in to remind them to breathe. And there are many reasons because of that. There's some reasons that are because of structural abnormalities again. Remember that brain stem serves so many functions when it comes to our respiratory system. Some of those is related to there's some systems in there. There's some receptors that actually help remind us that our carbon dioxide level is going up a little bit. So it would let us know, okay, you got to breathe faster so that you could breathe out your carbon dioxide. If our carbon dioxide is drifting low, that's system in our brain will say, okay, you got to slow your brain down a little bit, or slow down your breath so that you're not breathing off all the carbon dioxide, right? Now, if you have a problem in that center, there's some conditions we call Chiari malformation. So that it's almost like that brainstem area that's really responsible for sending those impulses to remind us to breathe may get squished. That is a big reason why some children might have central apnea. And the treatment for that is surgical. You need to literally relieve that brainstem compression so that they can start to breathe again. In some situations, you may need to put a child on maybe a ventilator or things like that, especially if it's super severe. So that's one really big, relatively scary cause. I talked a bit about the physiologic sort of causes that are not an issue. Then we also have some very interesting genetic conditions that essentially the brain just doesn't realize that it's supposed to be taking those big breaths. We call them central hypoventilation syndromes, or CCHS. And so essentially this is, a lot of the reasons behind this is because of a genetic abnormality. So again, super duper rare, but could be potentially, fatal if it's not detected on time. So what would the child present with? Again, it may present with a child who is having pauses in their breathing, where the parent is like, well, it seems like he doesn't seem to take big breaths when they're sleeping. In some situation, they may have detected it right from the moment the child is born. So the presentations are really, really wide. And then sort of depending on what the cause, in some situations too, we could treat it with oxygen, especially if the child is otherwise doing well. We could just stabilize their breathing with a little bit of oxygen and they're fine. So it's definitely quite involving taking care of those children. And a lot more specialization, a lot more fancy machines than your regular CPAP machine to help treat them if they need those kind of treatments. So, yeah.
So speaking of CPAP, I had this in my mind that we had all this time and we were going to talk all about all these different modes and stuff. I'm going to keep it a little bit more basic for folks, but just in general, what we know is our quote gold standard for treatment. And for kids, sometimes there's surgery versus CPAP, and I'm going to let you talk about that. But just in general, I wanted you guys to know, because I haven't discussed it in previous episodes, we call about CPAP therapy, or continuous positive airway pressure therapy. What we're referring to is you see people have the mask. You know what? I have show and tell time. I've got like heads here, so hold on. All right. This is the most ridiculous mask, which is why I'm showing it. I have like 0 people on this, okay? But the idea behind it is you're using some sort of a mask. This is a nasal mask. They do make full face masks. And it's attached to a machine, and literally the machine just is using air pressure. It's pushing air in, and you're literally just stenting open the tissue. And the air coming in is the same as the air going out. Now, nowadays we use fancier machines, which are auto CPAP machines, and they're like having, back in the day, we had everybody come to the sleep lab. We hooked them up with all these electrodes, and we would watch how their airway closed, and then we would titrate the pressure. And we still do often need to do titrations like that. We just do them much less often than we used to, because these auto CPAP sort of do it for us. So they kind of adjust the pressure according to what you need. So that is sort of treatment in a nutshell. Funke, please tell us some common things for kids that work.
Yeah. Great question. So treatment in a nutshell in kids, usually our first line treatment, because the most common cause of sleep apnea is related to big tonsils and adenoids. So really surgery to remove those tissues. And in some studies, up to 80% of it is curative. Now you have some children that may be at high risk, right? Children who maybe surgery is not an option, surgery is contraindicated. Or you have children who have like genetic syndromes where we don't feel they're safe. Or you have children who maybe they have return of their sleep apnea because they have other risk factors. So again, we talked about the children with low tone, like Down syndrome and other syndromes, or children who are very obese, where it's not just that the tonsils are big, it's the tongue is big, the neck is big, So in those group of children, we start to talk about the second forms of therapy, including CPAP, and then there's so many modes of that, depending on the severity and depending on the type. So that's usually what we do. And of course, as with adults, because of the relationship between weight and increased risk of sleep apnea, we also still recommend weight loss, but of course that's a journey, right? It's not something that's overnight. So we usually will have a bridge, either CPAP or surgery, as to bridge that gap. In some studies, we've seen that medical management is actually also effective if it's really mild sleep apnea. So sometimes we'll do a nasal spray where you sort of shrink just the excess tissue and inflammation that could be contributing to the sleep apnea. And then in a few situations, we do what we call watchful waiting, especially if the child is otherwise not too symptomatic. The sleep apnea is very mild. We may just observe them clinically and then see how they improve. And there have been studies that have shown actually that in some certain criteria of children, about 50% resolution can occur just by watchful waiting. So that's an option for treating in children.
So speaking of AHI, so apnea hypopnea index, how many times you stop breathing per hour. As I mentioned to you, adults, it's greater than 5, and the criteria is different for kids. I guess my question for you related to that is, one, does that change depending on the age of the child? And two, what are your feelings on home sleep testing in the pediatric population? I do know that if I was ever to use that, and intermittently I have, I typically am looking at, the 16 plus year old that basically is, bigger than I am. I'm short. I'm only like 5'2" on a good day. So, kids that are bigger than me that sort of like almost look like adults, I'm sort of like, I actually don't have an issue with doing home tests in that population, and I do know that people, for example, I've talked to some folks that may be working out of a Kaiser or just have a population where they, if they're in California and they're a section of California that doesn't have a lot of sleep labs, they're sort of left with what can I do to help the patient? So any opinions on those things?
Quite a few. So, in 2017, right, the AAS, the American Academy of Sleep Medicine, released this statement regarding home sleep apnea testing in children. And that is that it is not recommended for diagnosis, but then they put the caveat that, clinical judgment regarding the situation, exactly like you said, like during the pandemic or access, if you have a low access area where you can't necessarily get a child into a sleep lab, even in areas where we have a lot of sleep specialists, sometimes the wait times could be as high as 6 months to 12 months to get in an in-lab sleep test. So there are situations. Now, there are lots of studies now that have been emerging that are showing that HSAT may actually be valid, and two, it might actually be quite feasible. And there are different grades to it in terms of some home sleep apnea tests that are being used. Even some of my colleagues and friends who are really looking at this in certain populations, not just in that older sort of adolescent who pretty much looks like an adult, but also in these children with maybe Down syndrome or children with a lot of sensory issues that they just struggle with getting the sleep tests done in lab. And there are so many studies now that are looking at that. Some of my colleagues, again, Ignacio Tapia, Chris Cielo, actually are looking at this really on a very large scale, where they looked at this feasibility studies, looking at children who got the home sleep apnea testing, and they did it the same, pretty much either the same night or the night before. They compared them with their experience while they were in lab. And so they looked at it, and the sensitivities were both pretty good, and the specificities in terms of their accuracy in being able to detect sleep apnea for both were pretty close. More importantly was the total sleep time using a home sleep apnea test compared to doing the in-lab. The total sleep time with the home sleep apnea test was much longer. So the kids slept for longer. And then they actually looked at other outcomes like parent satisfaction and the parent experience with using these devices. And almost 90% of the parents and the families loved the home sleep apnea test. So without a doubt, I think we absolutely need this. But I would say the issue now is, how do we do it in a way that is safe? And how do we do it in a way that is going to be able to detect, all the things that we're looking for when it comes to these children? One thing I would mention, even for in-lab sleep studies for children, is one of the things we look at very closely is their carbon dioxide level. So remember, you're breathing in carbon dioxide and you're exhaling. You're breathing in oxygen and you're exhaling carbon dioxide, right? Now, for our children, we want to make sure they're not trapping excessive carbon dioxide. That's just so critical to measure and to address if they have sleep disordered breathing. A lot of these home sleep tests do not have that capability. So that's one. The other piece is when we talk about the flows, being able to measure, the pressure of air coming in and whether there's a cessation or there's a continuation of air, we need to also make sure that those are accurate in detecting both apnea, where you have complete pauses in breathing, as well as what we call hypopnea, where you just have a slightly decreased flow. And again, not all those devices have them. Thirdly, is the fact that a lot of these devices don't measure your brain wave activity to really help us know whether you're sleeping or awake. Most times they're using, some will use device, sort of like a motion monitoring or detector to kind of get a sense of, okay, I think this person has fallen asleep, right? But for us to know whether a child is sleeping or not is so important, so that we can see of the time they were in bed on when this device was recording, how much time were they sleeping. So we do want something that would at least be able to help us to detect that and measure true sleep, which is called the EEG. And a lot of these devices don't have it. A few of them have it, but a lot of these devices do not. And then finally, another thing we measure, especially in our children, a lot of our children are restless sleepers. And sometimes it may be because they have conditions like either restless leg syndrome or what we call the periodically movement disorder, which is a kick-in that children have that may be related to low iron stores. And it can be a big sleep disruptor. And so it's important. We don't want to miss that kind of thing, because if that's what's affecting the child's sleep, we want to be able to address it. We want to be able to diagnose it and be able to address it. Most of these devices don't have it. So we're not there yet. There's incredible fast action and research in this field. I think it's just a matter of time. I think there's a group of children that absolutely, I personally feel like, ripe for it. The other issue we're struggling with is insurance coverage, because many of these may be FDA cleared, but then, the American Academy of Sleep Medicine has put this statement out. And I think there's a body of people that are actually working on this as we speak to look at how we can modify that position statement, because many insurances go by it and say, absolutely not, I'm not paying. So who's going to pay for this? So a lot of work to do, but I think in the right hands, it would be great.
I'm going to just share a quick anecdote, which is I had a patient who really was she had had a prior kind of negative experience at the local children's hospital and wasn't really looking forward to have to spending a night there. And so they were asking about a home test. And I was like, I will check with your insurance. And sure enough, the insurance plan said, sure. So we did a home sleep test, and it was, pretty suggestive of sleep disordered breathing. Sort of more of a mild case, but nonetheless, I was pretty much like, I think I would give this person a trial, and, they're old enough that I wouldn't just send them to surgery right away, but rather, see if they could tolerate CPAP and how that impacted their sleep. And then the flip side is that they said, oh, well, she needs to have an in-lab study so we can approve her CPAP. And I'm like, I would have just done that from the get-go as opposed to even trying it. So you meet these crazy stories where you're like, I can't make this stuff up. I did want to ask you, because I had asked you a bunch of questions and you answered all of them so well. But just one thing is, for kids, is it still like that if you stop breathing 1 time an hour versus 5 times an hour, like, is there, what's the criteria for kids just for the studies?
Yeah, so mild, moderate, severe. We don't have it as clear cut as we do with adults. Again, it's pediatric sleep medicine it's still so in its infancy. But usually we'll say clinically significant sleep apnea. Technically the books say greater than 1 event, 1 pause per hour is sleep apnea. But what is really clinically significant? Usually we'll start to talk about anywhere between greater than 1.5 to 2, all the way to about 5 events per hour. So that's kind of mild. And then we'll say moderate is between 5 events an hour to about 10 events an hour. And then severe, usually people will go by over 10 events an hour. In some places, like we'll say over 20, because again, it's like, okay, you pause 1 8.5 times an hour. Like, am I going to put you through surgery, especially if you're otherwise doing well? Maybe not. But I think it's helpful to have that classification and really have conversations with the family, because just like you said, and there are lots of articles, if you even go on, online or PubMed and look at this, beyond the AHI, there's so many things that go into this, beyond the number of pauses that the machine is telling you have per hour. Like, what does that really mean? How is your quality of life? How is your alertness level? So we're really looking at this very holistically to determine a plan for the child, because especially for pediatrics, the plan for the child is the plan for the family. So, like, is this something that I'm going to put them through? Am I going to put them on CPAP for God knows how long? Or am I going to take them through surgery? Or is this something we can watch and maybe treat allergies, because allergies can play a role in sleep apnea? Is this something where we could say, okay, maybe some healthy habits and feeding habits, and we could get them to lose weight and repeat? So a lot of things play, a lot of nuances to how we approach it.
Funke, this has been such a fun discussion. I could literally talk to you for another hour, but I need to let you go. Oh my God, I just had so much fun today. Thank you very much for your time. You are amazing. And if you want to see her, check out Restful Sleep MD. We are kindred spirits. I am so excited to be part of this small but mighty, and I think growing community of folks that are really trying to take sleep to the next level. And honestly, I don't think it's really easy to do in our current medical model. So folks like me, folks like you, we're stepping outside the zone because it's necessary and somebody's got to do it. So really consider, working with her, and you'll hear my commercial and all that mixed in here, but I'm also available for consultation in New Jersey, New York, California, and Georgia at this point. Thank you, Funke. You are amazing. I'm really blessed to have met you. Thank you. This was really enlightening. I appreciate it.
Oh, thanks, Alison. I've had a great time.
If you are enjoying this podcast, if you feel that you are growing, you're more knowledgeable, you're feeling empowered about your sleep, that is the purpose. So please take the time to like and review the podcast. Share it amongst your friends and family. Please follow me. If you'd like to follow me on Instagram or Facebook, I am there as well. My handle on Instagram and TikTok is AskTheSleepMD. And you can also go to my website, AskTheSleepMD.com, for more information about each of these episodes. We will be sharing with you cited articles that you can actually refer to and read yourself if you like, and lots of juicy tidbits about how to sleep better. Thank you. This podcast would not be possible without the support of Mr. Joey Salvia, who is my producer, and Adrian Pederath, my creative director. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.